So, gentlemen, yesterday I talked about patients being able to sit and squat. We have Mr. Jaiswal, who's from Kanpur. भूल चूक से मेरे पास आ गए. He decided to come to Kanpur. मैंने कहा यार कानपुर में नहीं है, ये लखनऊ में है. लखनऊ भी आ गए दिखाने. थोड़ा stiffness है in one of the knees. चल के दिखाएंगे जायसवाल साहब. इनकी दुकान है बाय द वे कानपुर में, कपड़े की दुकान. मैंने दोनों घुटनों का ऑपरेशन किया है. आइए जायसवाल साहब, लौट के आए आप. सो ही इज़ वॉकिंग कंफर्टेबली, क्लियरली. 2 महीने पहले किया है मैंने ये ऑपरेशन, ऐसा नहीं कि 1 साल पहले किया. मेरे साथ नीचे बैठेंगे जायसवाल साहब? यार मुझे भी तकलीफ होती है नीचे बैठने में. दिस इज वॉट यू हैव टू ऑफर all your patients. This is what can be done for all your patients. It's a technique, it is an implant. Let's get on with it because this is what is required for our Indian patients. Any questions? That helps. Yeah. So that's all I wanted to say. I'm very grateful Jaiswal साहब कि आप आए. And धन्यवाद कि आप लोगों ने दिखाया सबको कि ऐसे भी हो सकता है. क्यों नहीं हो सकता? थैंक यू. हाँ दिखाओ. हमें भी टेका तो देना ही पड़ेगा यार. I do this with my hips also, by the way. Anyone who was there for the lecture yesterday knows that.
Thank you, very encouraging. Now, coming to the cup. Cup is a maze and very difficult to commit out.
This enthusiastic team, it's a pleasure to be here every time. I'll be talking of very, very basic things for my younger friends. It's not for Vidwan people, it is for our younger friends. I'll be talking about optimum cup positioning in THR. What is desirable? What do we desire? I bring greetings from my 2 institutes. And why do we need optimal cup position is for improved hip function and longevity. Now when we talk of cup position, what do we mean by cup position? We talk of 2 relationships of cup. 1, hip rotation center in relation to pelvis. And 2nd, cup orientation, which could be inclination or cup anteversion. When we talk of hip rotation center, it could be anatomic. I think Dr. Dhansekar has made my job very easy because he has talked about high hip center, but there will be some overlap and repetition. Hip rotation center in relation to pelvis could be anatomic or high hip center. And when we talk of anatomic, what do you mean by anatomic? Where lies the cup? So in terms of Dr. Ranawat, the cup lies in an isosceles triangle, which is about 20% of the total height of pelvis, just lateral to ilioscale line and starting at the level of intersection of ilioscale line and Shenton sac. Now what are the variations in hip rotation center? It could be medialized. Once it is medialized, the external offset is reduced and the femoral offset improves. So one example, dysplastic hip, lot of osteophytes, slight medialization, and this is 9 years follow-up. So medialization improves the abductor function. There is less wear because there is less joint reaction force on acetabulum, and it permits you more horizontal placement of cuff if you want to desire. It is within bony confines. Now another patient, again dysplastic hip with curtain osteophyte, in which we have put slightly higher hip center but within 15 millimeter of the opposite side. And another patient here again, in which slightly higher hip center has been put, but the cup is medialized. It should not be lateralized at all. Few more examples of dysplastic hips. Another dysplastic hip, type 3, marked anteversion. It was 70-degree anteversion. The head was lying in this area. The cup restored in its anatomical position using a bone graft. And that's the situation. What Dr. Chatterjee was telling, you can sometimes put stem and retroversion. This was the native anteversion, which was 70 degrees. That's the X-ray. That's at 3 months. We have restored it to the normal anatomical position by using a bone graft on the top. And good coverage, 5 years down the line, and that's 9 years, good function. So in this case, we brought the hip to the natural position, hip rotation center, to its native position by using a bone graft. Another patient in whom we have to restore in its native position. Now, how about putting it higher? Is it acceptable? Not acceptable? We should always try to put it in native position. Slightly higher hip center is acceptable. There are various studies. This is 15-year comparison of anatomical high cup position, and the authors say the results indicate that the moderate high cup placement without bulk bone grafting, because bulk bone grafting will have its own problems, at a horizontal locus, more medial, that's very, very important, than that of normal hip, is an alternative, durable solution, thereby saying that within limits you can put your cup at a slightly higher hip center. Same sentiment, same recommendation by Professor Ranawat, and similar recommendation by Larry Dorr in current concept reviews. He says the center can be medialized by as much as 7.5 millimeter, or it can be displaced by as much as 13, few authors have mentioned 15 millimeter superiorly without clinical consequences. Now, the cup has to be, it can be medialized, but should never be lateralized. This is a sin. Here, the cup is up and out, is going to fail very early. The surgeon has not removed osteophytes from the floor, and similarly here, it is lateralized, they are going to fail early. Dr. Beatty showed a lot of cases of good cementation, optimum medialization, but this case here, the cup is higher and out, which is a pitfall. It is not acceptable. How do you reach to the teardrop? How do you reach the medial wall? You need to remove the osteophytes at the floor. This is about putting the cup medially or superiorly. Another aspect, how about inclination and anteversion? What is the optimum cup inclination and cup anteversion? The story started way back in 1978, where Levinek recommended the so-called safe zone, in which he recommended that abduction angle of about 40 degree and anteversion about 15 degree is called the safe zone. And if you put this cup in this zone, there are very less chances of dislocation. So he showed it in his study within these parameters. If you put the cup, dislocation rate is 1.5%, but if the cup is outside the safe zone, chance of dislocation is 6.1%. And we were very happy. But is it true always? A beautiful paper in 2016 challenging it, and the heading, it is worth reading the heading, what safe zone? The vast majority of dislocated THA hip arthroplasties are within the Levinek safe zone for acetabular cup position. And this was a landmark study where they studied 9,784 primary hips, of which 206 had dislocated, 2% had dislocated. And in these dislocated hips, 84% of the cups were within safe zone for inclination, and 69% were within safe zone for anteversion, as recommended by Levinek, but they still dislocated. Now what the matter is, why it is happening? The biggest cause for dislocation of a hip in today's world is impingement. This is the major cause of subluxation and dislocation. Impingement could be bone to bone, or implant to implant, or implant to bone. And few studies, impingement of the prosthetic neck against the acetabulum rim has been described in 39 to 66% of cases of acetabular revision. Then what do I do? How do I place my cup? And what do I follow? I think the best guide is transverse acetabular ligament. There are n number of studies available recommending the transverse acetabular ligament as an intraoperative guide to cup abduction. If the acetabulum is dysplastic, you cannot follow this rule. If it is post-traumatic, you can follow this rule. But in majority, if it is non-dysplastic, non-traumatic hip, this statement is true. Transverse acetabular ligament is a good inclination guide, And this has been proved by cadaveric and computational studies that if your cup inferior margin is at the edge of transverse acetabular ligament, the cup is usually 44 degrees closed. If your inferior border of the cup goes inside by 5 millimeter, it further closes 30 degrees, and if it is outside by 5 millimeter, it is usually 64 degrees. This is cadaveric studies, computational studies. Transverse acetabular ligament is not only a good guide for inclination, it's a good guide for anteversion too, again, if the cup is not dysplastic, non-traumatic. And majority of cases we do are non-traumatic, non-dysplastic. So please use transverse acetabular ligament as an anteversion guide too. This is a study based on 1,000 cases published in JBJS. And we all know, we always see, whenever we start doing an acetabulum, we clearly see the margin, clearly see the floor, and we see the transverse ligament before we start our reaming. So use TAL as a good guide for inclination as well as anteversion. And just few examples. This is parallel to the TAL, and this slightly inside, slightly closed cup. In few cases, you will need mental templating with knowing these parameters. You have bony margins available, you have TAL available, you know what are you doing. And one or two difficult cases, how can this even mental templating might help you. This was the post-septic case, came for, we wanted a mobile, painless, stable hip, and we did hip replacement on this patient. Is doing well. Now another thing is, whenever you see a preoperative X-ray and you know how much cup you want to close, have a mental templating, how much cup would you look, will look uncovered intraoperatively. And similar thing you can reproduce on table, and then you will have a satisfying X-ray. So what is my ultimate goal in cup position? What I want is impingement-free range of motion at the hip after implantation of cup and femoral component. That is the safe zone. So you need safe zone for certain activities which are like picking an object or low chair rise. I would not recommend squatting, but then in these activities the safe zone is very narrow and we are supposed to achieve it on table. How do we achieve it? Long back, Laridor told us, combined anteversion technique for total arthroplasty. And Dr. Dhansekar pointed out, in difficult situations, you are supposed to achieve good combined anteversion. Now, what does combined anteversion mean? It is mating of the femoral head in the cup without impingement of the two throughout all body positions, the required activities you want to do. And the recommended combined anteversion by Laridor was, in males aim for 25 to 35 and in females 30 to 45. How do you test it on table? By Ranawat's coplanar test, you can test it. Now, whenever you're putting a cup, beware of large osteophytes, which you are supposed to remove, otherwise there'll be impingement. And we want impingement-free zone in majority of activities which you can test on table: flexion, adduction, internal rotation, abduction, external rotation, and all zones, safe zones you can check. So the combined anteversion, the nature's method of the stability, and it is the most important measure for stability in recommendation by Laridor and the group. And combined anteversion explains why the hip remains stable throughout the wide flexion arc. So you do stay in safe zone, but keep combined anteversion in mind. Now, few lines on spinopelvic mobility. Professor Ruman has published a good paper in Arthroplasty today on this aspect, but I'll be touching only very, very basic few practical points. That's the normal sagittal spine-pelvis-femoral relationship. The picture on the left is when you're standing, and picture on the right when you're sitting. From standing to sitting position, the pelvis tilts posteriorly, the acetabulum opens up anteriorly, and of the native acetabulum, there is increased anteversion and inclination. So, just basic ones. So if normal spine, not stiff spine, flexible and balanced, normal anteversion and inclination. But if the spine is rigid, kyphotic or less lordotic, then there are chances of posterior impingement while standing. So you decrease the cup inclination and anteversion on table. And in case the spine is stiff, rigid, and lordotic, then there are chances of anterior impingement while sitting. And in this case, you increase the anteversion, give more opening anteriorly, and you are safe. So, summarizing, cup position in an ankylosed spine, like in ankylosing spondylitis, you can remember less lordosis, less anteversion, more lordosis, more anteversion. Very simple to remember. Once you're happy with the position, you need to be sure on table, have I fixed my cup well? Is it rock solid? So, is it strong enough? Just small video to share with you. When you fix the cup, you follow the sound. Is the sound there? It is not there. As you reach the floor, the sound changes. And once you are happy, try to move it. It should not rock in the socket. The pelvis should move. And once you try to rotate hard, you should not rotate. This means you have got at least 3-point fixation and your cup is rock solid. You can add additional screw if you wish, but your cup is rock solid. Thank you very much.
Thank you, sir. Nice and excellent presentation. Any question you can ask from the delegates?
I'll just say you demonstrated the best technique. That was the best technique you demonstrated. Only question, when you would like to use a screw and when don't?
A true hip rotation center.
No. When you would like to fix with a screw or when you don't?
So ideally speaking, if you've got good fixation and don't need any screw. If you're solid, you don't need any screw. But even slightest doubt, then you can add 2 screws minimum. That's a recommendation. Suppose you cannot go up now, you have reached your anterior and posterior column, you're seeing they are thinned enough, you can't go up, and you by chance you're not happy with that, then you can, but at least you should have stability in rotation. If not rocking, at least in rotation. At least there are at least 2 points it is fixed nicely at 2 points at least. There is a question.
Good afternoon, sir. My question is, hello.
Can we make it loud? There's a lot of noise
Hello.
background.
Sir, my question is that, as you said, there is a lordosis, increased lordosis or increased anterior. What about the cup position when there is a pelvis tilt? Not that inclination and that version is different when there is a pelvic tilt.
Okay. So if there's a fixed pelvic tilt and opposite hip is adducted, means the pelvis is up. This side, the operating side is going to be down. You put slightly open up cup. And if it's just opposite, the other side is down and your operating side is up, then you put slightly closed cup. If it is fixed, we are talking of fixed. If it is mobile, that's okay.
What about the version?
Version shall not change. In pure, this version should not change. It is in forward and backward, it should change.
Okay, thank you.
Your practice,
Not able to hear.
sir, in your practice, how many times do you come across retroverted acetabulums and what do you do for it? Do you put it in the same version or do you kind of cheat a little bit and put it in the native acetabulum direction?
To be very honest, I have not seen the so-called classical retroverted, but if I get one, I will still follow the tale. I tend to restore.
If you follow the tile, it will put it into until retroversion.
So I'm coming to it. My aim is to get impingement-free range of motion, right? Now patient has a retroverted acetabulum, naturally would have some compression in the femur also. I will not make a major modification in that. Maybe just neutral. I have not encountered this situation, but if I were to do that, maybe just neutral, minor, because I use uncemented stem. So minor change in the femoral side, minor change. And then see where is my impingement-free range of motion is there or no. In sitting position, standing position, and then I will change it accordingly.
I found that the native acetabulum, the fixation is best in the whatever direction it is actually in.
So that's why I'm saying very minor modification I'll do. I'll put a trial first. I will not fix my cup. Put a trial, see. My aim is to get impingement-free range of motion in all activities. If it is 5-degree retroversion, no problem at all. If it is, but not a major retroversion.
I think I do agree with Dr. Anil Arora because using the native acetabulum, but remember you have got a native femur as well, which is matching to that acetabulum. So do an acetabulum where you have got bone all around, and then do a trialing, and as Dr. Arora showed, the coplanar test. Because in the femur, you can change your anteversion. So get a matching anteversion to that acetabulum which you are doing. And this we always do in the dysplasia, so there's nothing new there.
And there's a crossover sign. If you see X-ray, there's a crossover sign in preoperative. You can see that. But how many of us have seen non-dysplastic hips retroversion? That seems to be more theoretical.
Dysplasia is a different ball game altogether. I think Dhansekhar want to watch.
It's quite rare, but it's not uncommon. I did a case of primary idiopathic AVN of the hip. And intraoperatively, I found the acetabulum was retroverted. So, but luckily, patient had an MRI, so I could cross-verify with the MRI, and actually the socket was retroverted. I could correct it intraoperatively. So it can happen, and
Post-traumatic you can
only
have.
the cup placement I changed.
The lower
I didn't
one
go with the
rotates.
TAL. I just use the jig to place your cup.
So we can always change because you see before this TAL thing came into so much of practice, the classical teaching was to see with the inclination and angle and anteversion, everything was different, where we were changing the anatomy of the patient to make a mechanical joint. Now we have moved more towards the physiological loading of the joint, but initially it was, the Charlie said that was a combined, even coplanar came later on. Anything to add, Doctor?
Post-traumatic situations, also you can find a retroverted acetabulum, especially with malunited acetabular fractures. And also some of the cases of these dysplasia long-standing, the femur is grossly anteverted. But to compensate, actually, in some of the dysplastic hips, you will find an altered anteversion of the acetabulum also. You've got to be extremely careful about placing the cup there. And I think it's better to go assess the CT, study the CT probably. Intraoperatively also, as we ream, we have to assess where the anterior and posterior wall is and adjust the anteversion accordingly. Because you can't err on the normal side.
See, undoubtedly, dysplastic is a different ballgame altogether. I think what he was asking was in a normal situation, non-dysplastic.
Yeah, we should know where you should not use TAL. So, acetabulum fracture, dysplastic hip, spinopelvic malalignment, these are situations you should not go with the TAL.
Sir, I have one question, sir. Sir, when the cup is fixed in particularly cemented type in a more vertical and less anteverted position, what changes you can make perioperatively in a femoral fixation? And secondly, if the whole thing has been happened, will you advise for a bed rest for longer time? For most of people say कि बहुत दिन rest करो, fibrosis होगी, सब कुछ ठीक रहेगा. So will you survive for longer time or not, sir?
So, in a cemented cup, once you have committed, you can make very minor change on the femoral side. And bed rest will not make any sort of difference. If it's passage, it will dislocate. You have to correct on the table if you want. Nothing will happen by bed rest. So that's a false assurance.
It has to be revised.
You have to be correct.
Thank you, Dr. Arora.
Sir,
one more, yes.
Very primitive problem. Hello. Very primitive question, sir. While doing reaming, the homen which we put below the TAL tends to create piping, and the angle we desire, the fascia lata, tends to make it more vertical. So the tips you can give.
See, fortunately, I do all my hips by lateral approach. I don't do posterior approach. And it is in front of you. I just put a spreader, laminar spreader, and everything is in front of you. I don't use that inferior homan at all because it interferes in my closing cup. It tends to make it vertical. For this same thing, so I've been using lateral. I can't answer this question because I don't use posterior approach at all unless I'm doing a revision and ETO. Otherwise, all patients I do, even all dysplastic hips, lateral approach.
Okay, Kapil, I will show you. I'll show you a small video where how to expose the acetabulum.
In lateral approach, if I find it difficult, I slightly take more exposure. It doesn't come up my way and I can close the cup.
Thank you, Dr. Arora,
Thank you, sir.
for a wonderful disposition of position of the cup.
I am getting deceived by his looks.
Sir, after hearing you play your instrument yesterday, I think I'm nowhere near your youth. Nowhere near it. So,
you look like a Bombay film hero, yaar. आप संजय अग्रवाल के पास एक बार चले जाओ, competition दे दो.
That goes to Dr. Mudit Khanna because you already said that yesterday.
Yeah, that. He takes the cake, that's definitely.
All right, so I was asked by Dr. Prasad to speak on this, and I think it's a topic that we all would be interested in because that's one of the first things we do when we are residents and trying to graduate. We do bipolars, we do hemi-hip replacements, and sometimes you have to revise, and after a course like this, you go back and you get a patient like this and you say, okay, I'll revise it, it's not so difficult. You hammer it up, okay, this has shifted, I'm really, really sorry. I'm going to remove that, that's the wrong one. Yep. So you get a case like this and you say, I know how to remove this. You've learned it in this course. You just push it out, you put in this solution stem and you say, wow, I can revise the bipolar, no big deal. But every bipolar is not the same. You will get cases like this, you will get cases like this, and you will get cases like this. So you have to understand that you have to plan after a proper understanding of the processes. So the principles are you must know first what you're dealing with because every case is different. You must know your foe. Is it a pussycat or is it a tiger? Plan your surgery because planning requires understanding not only of the problem itself but also what you will need during the surgery. What are the armamentarium you got to go with? And then of course you execute your plan. The principle, of course, for any surgery, including revision, is to preserve as much biology, preserve as much bone as you can, preserve damage because you may need to do it again. So what must you know? You must know whether the stem itself is stable, just like you would do in a revision. You must know whether the stem is extractable easily or not. And trust me, cementless stems are not easy to extract. So be prepared for that. And try not to damage the greater trochanter because that's your life saver. Otherwise, you'll end up with dislocation of whatever you do. So the greater trochanter, the abductor mechanism is your life-saving guide. Keep that in the back of your mind and in your heart and your hands all the time. What kind of fixation method will define what kind of processes has gone in? So it's cemented or non-cemented bipolar or hemi. And what kind of defects are you going to be dealing with on the femoral side and how is the acetabulum? So this, for me, is your most important slide. If you pick this slide back home, you'll know how to do it. So let's go one by one. What are the possible complications? We know there are trochanteric fractures, there are defects, there are femoral shaft perforations, there are shaft fractures, and you can also break instruments. So you have to also plan for those things that can happen. And what do you need? You might need a simple stem extractor. You will definitely need flexible osteotomes. You may need high-speed burrs with tips. You may even need metal cutting burrs. A trephine, sometimes, if you want to remove, and giggly wire saw, keep it with you, it's already there. Pulsatile lavage, if you're going to use any of these instruments. So how do you execute it? You have to have decent exposure. So my advice to all surgeons, learn how to do the hip replacement through the posterior approach, through the direct lateral approach, and if you can, also through the anterior approach. So learn all the ways to do it because you may need to do dual approaches, you may need to change your plan intra-op. There are going to be problems in dislocation. There's going to be problems in extraction. Be prepared. You have to reconstruct both the sides and you have to make sure you don't cause defects and you must know how to manage those defects. Protrusio is a big problem with hemi-arthroplasty, especially the older Austin-Moore prostheses, Thalwalkar prostheses, and sometimes with the bipolar. And of course, the key to a good surgery is a good soft tissue balancing. So let's go one by one. In exposure, we know there are going to be difficulties in protrusio. There are going to be difficulties if the patient has got osteoporosis or osteopenia, and there may be soft tissue contractures. So take care of these when you're doing the surgery. You may want to do a controlled trochanteric osteotomy or a gluteus medial release, but you definitely would need a capsular release to dislocate, especially patients who have got protrusio. And the failback is your extended trochanteric osteotomy, so learn that as well. As far as dislocation is concerned, I said you can sometimes manage with just the posterior approach, and this is one place where I use the posterior approach. I was trained in the posterior approach. I started doing a lot of hips with the anterolateral approach, then I had to do them again for revision of my bipolars. Sometimes dual approaches, and like I said, you need instruments to pull out the implant sometimes. So extraction cannot be easy all the time. For cemented prosthesis, it's relatively easy because you just have to clear the soft tissue and the granulation tissue around the upper end of the prosthesis, and you can just punch it out or hammer it out because the cement prosthesis are usually smooth and they're actually not fixed into the cement, but they're actually just sunk into the cement. So you can just pull it out or just back tap and hammer it out. Whereas cemented ones can be a challenge. So somehow it's not moving ahead there. Yeah? Yeah. So I can see the next slide, but you guys can't. But in essence, the cement removal is tougher than the cemented stem removal. Keep this in mind. So there may be times when you don't want to remove that cement. There may be times when you want to remove the cement. If you want to remove the cement, there are two ways to do it. You can go from the top, what we call the pro grade or the anti-grade method, where you gradually chip away at the cement, gradually release, gradually use thin flexible osteotomes, wires, small burrs to remove the cement by piece by piece by piece by piece and try not to damage the proximal femur. That's one way to do it. Once you come to the cement restrictor or the distal plug of the cement, there are two things you can do. If it's something that you find the canal is wider distally, you just punch it in and let it stay, if it's aseptic. But if it's septic, then of course you got to remove that. So you can do it by making a small fenestration distal to the stem. Or then again, if it's really fixed well, which is usually the sort of a paradox in infection, then you want to go back to your trochanteric osteotomy. Right. No problems, it's okay. Now I wanted to show a small video which is basically of a cement in cement revision, but for lack of time, I'm just going to skip that because it shows that you can just pull out that cemented stem and then you can just use a burr or use a cement dissolving ultrasound device and just open the space a bit so you can create slightly bigger size canal along with the cement inside.
Dear Dr. Thakral,
Yeah, it's okay? Okay.
everybody will like to see that. Yeah.
All right, so I was talking about the extraction of this cemented processes. All you got to do is remove that little granulation tissue around the implant, and all you got to do is tap it out, and you'll get a nice looking hole like that. The problem is really removing the cement. So cement extraction can be done through the pro-grade technique, and then once you go down to the distal plug and the cement, you can either push it distally if it's aseptic, and if it is adherent or something, then you may have to make a small hole distal to the position of the cement and tap it backwards. So because otherwise what will happen is when you put in a reamer to put in your stem, you will go eccentrically and you may cause a perforation or you may cause a fracture. So be careful of that. And of course, you have the extended trochanteric osteotomy, so I won't go into the details, but this is something we've published and we do quite frequently in revisions now. For cement and cement revision, if you're worried about, or if you're thinking that the cement mantle is really well done, then it's a good idea to actually leave it, especially in aseptic scenarios. So you want to maintain that cement mantle, but actually it's only possible if you have put a larger size cement prosthesis earlier and you can manage to put a smaller size cement prosthesis. So if you say starting off with a big size 3 and you want to end up putting a size 1 or a size 2, you could do that. So you can just manage to burr out the cement. I'll just show you the video here. So after you've done this and you reached here, so I'm going to skip again because some part of it is not so important. Let's start out here. So the processes come out and you want to put the smaller one there. And so what you're going to do is you're going to go around your prosthesis, just put a trial, push it inside first in the same space and see up to where you want to put it and do a trial reduction, because ultimately when you put in the new prosthesis, that's the level you got to go to. You don't have too many modular options to make it much longer or much shorter. So you have to be careful of where you ultimately want. It's again gone. I think they don't want me to play. So like I said, I think I'm probably virus for this. All right. चल रहा है? Trial reduction, because you want to know up to where this definitive stem that you're going to put in now, the smaller size stem is going to sit. Otherwise, what will happen is you will end up pushing it distal inside a bit more. Now you can use small words and you can sort of remove that cement, or you can use a Oscar device and you can just dissolve some of the cement around it, so you have new space for the next batch of cement, which again you can use a cement gun and you can push it inside and then put in your prosthesis after packing that cement, pressurizing the cement up to the level you've decided. So this is important. That's why you got to do the trialing here before you start preparing the canal. And once you've packed that, you can see the junction between the new cement and the old cement, and then you can do the reduction and you can get away with a smaller size implant, as I showed you in that. That's your cement and cement femur. Whereas cementless stem extraction is actually a pretty tough job. I mean, all of us have burnt our fingers many times trying to remove the whole of it. I think if there's a single thing to do, I'll tell you to straight away go for a extended trochanteric osteotomy and try not to remove it through the different methods described here. This is a video I borrowed from Professor Luca Marega. Again, this is perhaps not working. Let's see. Does it work? Yeah. So Dr. Luca Marega is just going to show us a few different sort of ways to remove it. Again, he's removed the granulation tissue and the loose bone that is there around the neck of the prosthesis, and the stem is just visible there. And after that, using birds and using small instruments, he clears up the space to pass in thin flexible osteotomes or drill bits down by the side of the canal. All the time making sure you have pulsatile lavage to clean it off. And after you've created space, you can check whether it's sort of amenable to an extracting device like that, which you can just punch it in and punch it out repeatedly. And with a good bit of practice and a fair amount of luck, you may actually manage to pull the whole thing out in one piece. Sometimes we have seen that the proximal fragment comes out separately along with it. So be prepared for surprises here in revision scenarios. So if it's proximally coated alone, this is something you can do. However, if you have things like this, you have to go around it, and sometimes you got to make sort of a fenestration on the outer side of the greater trochanter, just below the greater trochanter on the outside, and punch it out from that side. So you can also make that little window out there on the outer side, and then again open it and clear it, and you can pass in your giggly wire saw, loosen that prosthesis, and then just tap it out from the lateral side. Once it's loosened out and cleared out, just tap it out and it comes out from the neck portion. But these are all, difficult surgeries. You're going to take a lot of time to do it. This is something you should be aware of. That's all. And sometimes if you have, especially in the bipolar systems where the head locks inside the plastic of the bipolar, you really can't dislocate it. Sometimes you may actually use metal burrs to cut off the neck, the metallic neck, to sort of dislocate the head. The femoral reconstruction then becomes easy. Once you actually removed all of the cement and removed all the implant, then only you can do reconstruction, and the defects are identified after the extraction of implant. So you actually classify them whether on Paprosky, AOS, Mallory, or Gross, but predominantly the Paprosky classification after you've removed the stem and the implant. Diastabular reconstruction, luckily for a failed bipolar, is not so difficult. You may need bone graft, so you can do impaction bone grafting either from the iliac crest or take autograft, and there are other options available, as you have already heard in the lectures before me. But soft tissue balancing is the key, and soft tissues have to be balanced. So have a clear idea in your mind about how much you want the tension to be in the soft tissues as soon as you put in the definitive implants, and try to replicate that when you do the surgery. So that's the case. We've seen the 3 different cases that I had sort of showed you in the beginning, and I said, look, it's not the same. They're not the same as the early case. Let's see how we tackle each of this. The first one, as you can clearly make out, you just can't simply go from the top. So here we did a classical extended trochanteric osteotomy, removed the stem, and then put in a long solution stem with cerclage wires, which of course went into heel. A few brave ones would probably attempt to do something else. That's a patient who fell down and actually fractured her acetabulum. Now this is a cementless stem with a bipolar cup on it. Again, if you really wanted to do, you could go down and do whatever we saw in the video, but we chose to be prudent and we did an extended trochanteric osteotomy for a cementless stem and then revised it on the cup side as well. Sir, it was not possible to dislocate it otherwise. All right. And the last case was actually done by my junior while I was on a conference like this one. He did a fracture neck femur, he did a bipolar, and that dislocated in a month's time. And the reason I found out was that because he had given too much lengthening, not understanding that soft tissues were not, to be, they were supposed to be respected. You should not try to get them to the tension in the soft tissues, but what you have on the opposite side. So this is what the immediate post-op X-ray was, and this is what happened in a month. And so, of course, in this case, I had to revise it to a long stem cemented because of financial constraints. And this is what I did from the pro grade, from the top. I removed all the cement piecemeal. So this took time. And I caused a little bit of a fracture in the trochanteric region, so I had to wire that. So that's her. Walking at 4 days. So she was much better after that, after she started walking. So that was good. Right. Now, there are some other cases like this where you have to be very careful where you go down into the stem, because if you just follow the natural curve or the course of the stem, you might actually cause perforations laterally. So be careful. There's protrusio, there's osteolysis of the calcar, and there's osteolysis of the lateral cortex. So you be careful of these three things. So take each case by merit. Do not have a cookbook approach for something like this. A revision in any case will have its own challenges, its own ultimate okay, I'm going to forget the videos, otherwise, again, we'll have problems. I think it's again stuck. But in short, what I wanted to highlight out here is that there is no just single one way to do this surgery. You have to accommodate for all possible problems. I showed you a slide in the beginning. That's your take-home slide. But understand which kind of problem you have in front of you. Know your foe first. Prepare yourself, arm yourself properly with all the possible necessary instrumentation. Preserve bone as much as possible, because bone is your friend. And of course, gain experience. Don't try to go back after this course and start doing revision of cemented or uncemented bipolars from tomorrow itself. If they're well fixed, as Dr. Prasad just asked me, do not remove them. Please don't remove them. You must be hard pressed because of some stupid reason like not getting dislocation to remove them. And yeah, but if you're ready, then you will, of course, think of it beforehand and use modular heads and dual mobility cups wherever in doubt. Thank you.
Thank you, Dr. Kunal. Any questions from the house?
And sorry for that, my opinion.
Your opinion about the dual mobility cups, how do you weigh it versus the other one?
Versus which one, sir?
Normal,
Standard.
The standard bipolar.
Yeah, so, I mean, I'm a fan really of going conventional wherever possible. Only where I'm hard pressed, I would put in a dual mobility cup. I'd only put it, say, where I, say, for example, didn't have too strong abductor muscle at the end of my procedure, and I was worried about dislocation. Now, the problem is you will get dislocation even in bipolars in this kind of a scenario, so you have to be prepared for it.
A lot of time we have problems with the Indian patient. They have thin diameters, like 9 or 10, and they have bowed femurs. Then how do you go for these long stems? And or if you do cemented in these, it might cause penetration of cement and non-unions.
See, you have to understand that not all implant companies provide all different sizes and shapes and diameters. So you have to actually already do that homework and catch on to a local manufacturer, and then ask the exporter, the Depu, Synthes, and the Striker people to provide you with the proper sizes. Otherwise, you'll start using the local ones. So threaten them a bit. That's the only way it works. So if you ask them, they'll provide it to you. And this is not an emergency. You can plan the surgery and do it.
Any other question? So just I want to make a comment, Rajiv. Sometimes you get intraoperative surprise. You get your basic workup done for infection, hemogram, ESR, quantitative CRP, that's normal. Recently I operated a case, CRP was normal.
Yeah.
It was a revision THR. When I operated, I found a membrane sent for intraoperative cell count. the frozen section. It was infected. And it grew Pseudomonas struthergism, some very abnormal. Did you encounter such thing?
Yes.
Or you are happy just by doing a quantitative CRP normal?
No, sir.
Do you ever send material for intraoperative frozen section in all cases, suspected cases?
So if it's not explainable, the reason for the failure is not explainable, then definitely I would send for cultures. But if it's a clear-cut indication like a fall or an injury which caused this implant to fail, then I wouldn't do it.
Yeah, so I'll be very wary when a patient comes early, done 3 months back, 6 months back, severe pain, rapid chondrolysis, think of infection. Flexion deformity, lot of muscle spasm, think of infection. No matter, quantitative CRP just is not adequate to rule out. We cannot rule out infection with that.
So the most difficult, your topic about bipolar revision to total hip. So the most difficult situation I have faced is a cemented Austin Moore prosthesis.
Yeah.
Have you ever faced this situation? Because the problem here is the fenestrations are filled with cement and it is a collared kind of a prosthesis, so you can't get your osteotome in to sort of break those bridges. So how do you tackle this?
Sir, for me, the workhorse is the extended trochanteric osteotomy. Wherever I have a doubt, especially in these cases that you're talking about, I don't mind actually straight away going to the extended trochanteric osteotomy. Unless I can do a cement in cement revision.
In bipolar, kind of this process is cemented. So I have designed this kind of intraoperatively. Make a drill hole over the bipolar head and you thread it over the nail extractor or either some nail extractor and make a hammer by thread this bipolar. You can extract this so many things anytime.
You're right, people have used that.
If it is cemented
and
Austin Moore, it will not work. If it's a cemented Austin Moore, it will not work. It may work in a Thompson's.
See, why sir is saying is because the cemented Austin Moore has got those big fenestrations. And if you put cement, that the fenestration allows cement to penetrate from the front to the back. So you have a bridge of cement.
Second thing, to avoid this extended trochanteric osteotomy, you can free from by the osteotome, small osteotome up to the zone 1. And you make a window at the subtrochanteric region at the zone between zone 2 and zone 3. And I think by this process, you can also avoid the extended trochanteric osteotomy. You can save the abductor, I think.
The problem with an ETO in an Austin Moore is the Austin Moore stem is pretty long. So your ETO goes almost halfway down the femur. That is one big problem with doing it in an Austin Moore.
Right.
Rajiv, the biggest advantage of ETO I see in a patient in whom there is some element of protrusion.
Yeah.
It helps
Yeah.
not only in, you go home early, in the sense it makes surgery so fast, so easy. And if you are using a solution stem, I've stopped using it now because I burned my hands in many cases. Solution stem is a very difficult one to use without ETO.
Yeah, I totally agree with sir. So. I had to revise it. There was no choice.
Any more questions? If not, thank you very much, Rajiv.
Thank you.
You enlightened us.
It's been a great pleasure to have all these esteemed faculty with us. They are the glamour of our course, and every time when they come, they bring more shine to our course.
We can request Chandrasekhar to be a permanent faculty for Kanpur Arthroplasty. The other person we should thank is our core member, Dr. Amit Rastogi. He is going back to Banaras, the holy city, and he is a permanent member, so no issues there. So thank you, Amit. Thanks for being with us.
Thank you. First of all, I would like to thank Dr. A.S. Prasad for inviting me here and share my experiences. And earlier, and thankful to Rajiv also. We had so much of discussions over this topic earlier, but I would like just to share my few experiences. This is a case of revision hip arthroplasty with severe osteoporosis, broad type C canal, cemented bipolar has been broken, and with protrusio. So this is a common condition, but would like to share my few experiences. And it is sometimes it is really very difficult to go for these cases. And I would like to suggest that all my young juniors that always when you go through these cases, always make your mind. Don't be stick to one plan A, B, C. We have to be very careful. Don't stick. Allograft, Rajiv have covered almost all the things. Allograft, autograft, or in these cases sometimes you need in severe osteoporotic. I have used fibula also for lateral when there is a perforation in lateral wall also. So it's like a femur treated by Hemi 4 years back with broken prosthesis and protrusio, and patient have a history of re-trauma few days back that leads to broken prosthesis. See, this is the axis. This is how highly osteoporotic, severely osteoporotic, broad type C canal is there, and these cases are really very challenging. So we have to be ready with every options. Removal challenges in this case, that is removal of broken implant, removal of bone cement, removal of problem severe osteoporosis, osteopenia, deficient acetabular wall, and post-operative complications also. And how to proceed? First of all, implant removal. It was a cemented bipolar hemianal arthroplasty, so main task is to removal of stem with cement. For this need, we need to have an ETO or make a window in femur by which we can remove cement and broken stem. Initially, we have various methods, like we have an antegrade method or what. And my suggestion is to have, when you approach or going for these cases, don't hesitate. Have a good exposure. Have a good exposure. And in this case particularly, I made a mistake. I was some lethargy or somewhat. I used to start my extracting. I extract the proximal part of the implant, and I thought that it will be removed easily. So there was a little bit perforation in the lateral cortex. So I immediately changed the plan, have a wide exposure. And few cases with osteoporosis, I doesn't do ETO. I make a small rectangular window that starts osteoporotic bone. So I always go for window formation for removal of cement and broken implant. And after removal of cement and broken implant, we go for in this case PHR, because acetabular wall was also deficient in this case. So I used tri-flange cage for acetabular component and used a long femoral component, and window was closed with the application of SS wires. This is how it. So in this case, I avoid, because of severe osteoporosis, ETO, I make a window starting from distal part of the broken implant and distal 3 centimeters below the distal part of the broken implant. So that rectangular window, I was quite comfortable. I was comfortably able to remove that broken implant with cement. In this case, I didn't do extended trochanteric osteotomy. This is how this window I make it. Because of osteoporotic condition, I avoid ETO in this case. And after removing all this, put SS wires, use a clamp. And in this case, I was specially ready with fibula also. See, suppose I didn't have any lateral cortex for any support, I'll ask my assistant to drape the fibula also. So, appropriately, I didn't find any other thing that I should place fibula in this case. This is how that was immediate post-operative basis. As posterior superior cortex was there, dome was sufficient enough. Due to protrusio, I use a tri-flange cup, and with tri-flange cup, I use cemented cup. And especially in these cases, as Dr. Sanjay Agarwala said, that we have to be very careful about the version and inclination of cemented cup. It should not be vertical. We have to be very careful. So I use the cemented cup, have a good posterior superior dome, and screws were sufficiently engaged in the cortex, and I put a long cemented stem. This is 1 month, 2 months, and 3 months. And last she visited few days back to me, It was 6 months follow-up. She was walking without any support. So 6 months follow-up. You can easily cement. There is a little bit of cement is popping out of lateral cortex. That was due to perforation that I had. And immediately I changed my plan that I should do that make a window. Especially in osteoporotic patients, I make a rectangular window. I didn't do ETO. So this was the last follow-up, 6 months follow-up, and I think, sorry. So this was the case. So only I want to give a take-home message in this case is that don't stick to one plan, always ready with, and where there is a chances of broken lateral cortex is there, deficient latex, you should be ready with fibula graft also. In few cases, I have used fibula also, and they are working quite well. Thank you, sir. Thank you.
Thank you. Can you show the post-operative X-rays?
Okay.
You had a series.
Yeah.
Just the post-op one.
Yeah. This is after 6 months. Okay. Oh.
No, not after 6 months. Immediate post-op and then
okay.
1, 2 months and 6 months.
Okay. This is after 1 month.
Okay.
2 months. 3 months. This is after 6 months. And I have used posterior approach in this case. I'm quite comfortable.
Why did you not use a cementless stem in this?
Sir, so type C canal. So osteoporotic, and I was not comfortable with cementless stem in this case.
Just want to reassure you, whatever revisions we do, about 20-25% patients will have osteoporotic bone, especially in old patients. Either osteoporotic or paper thin lateral cortex. So doing an ETO is not a problem at all. In a sense, one has to be very careful. And they all unite well. Why I'm saying you need not to make a large window. One can do an ETO that makes your life easy for access to the acetabulum also. See, ETO not only helps in extraction, but like we put a cage. You need large exposure for that cage also. So doing an ETO and osteoporotic bone is not a big game, number one. And God forbid, slightly gets fractured. Doesn't matter, it unites.
Okay.
With passage of time, it may take 4 months, it may take 6 months. It always unites. Almost always unites, I would say. Now, if you're planning a cemented stem, I'm sure you had kept in mind that I want to keep the funnel unbroken. That's why I took a lateral cortex. Because I think you had planned a cemented stem. Or I think in our country, money is also a big issue.
Yeah, definitely.
There's a big issue with money, buying an uncemented stem. This is not a bailout option, I think. But if I have to do in ideal circumstances, would love to do an ETO, put an uncemented stem. And on the inner side, whatever patient can afford, right from cage, cup cage, whatever patient can afford.
The reason why an ETO unites very well is because it is a vascularized bone. You have the attachments at the top, all the abductor muscles, and anteriorly you don't actually strip the soft tissues. So when you crack it open, you have a completely vascularized bone. Now the problem with a big window is that window part becomes devascularized. So actually, effectively, the union rate in a ETO is better than in a window.
Maybe same thing. No, he had to keep in mind that I have to put a cemented stem. So that was in his mind.
Actually, there was a perforation of lateral cortex also.
Yeah, I see cement, it has seeped out.
Cement pop out from that lateral part. Sir.
Can I make a quick comment? I think the general rule to be followed when you make a window, it shouldn't violate more than 1/3 the diameter of the tube. And that is, I think yours was almost hemi-circumference. In that situation, you will not have a problem with the distal propagation of a crack or even the proximal for that matter. And always start the preparation with the prophylactic wiring distal to it, as well as, because that will prevent your propagation of the cracks or even any further fractures down the line. A good procedure, but I think when you make the window should not be more, it can be longitudinal, but shouldn't violate more than 1/3 the diameter of the tube. Then it becomes a problem. Union is a problem, crack propagation is a problem, and your stability for the revision implant is also a problem. 1/3 circumference, circumference, diameter, circumference.
Why did you use a cage in this case?
It's a triflange cup.
Okay, triflange.
Triflange cup because protrusio is there, na?
Okay.
If no questions, then I think.
If
Thank you very
there
much.
are more questions?
Thank you, Dr. Kwan. Thank you very much.
So we are just a little bit violating the program.
Good afternoon, everybody. So we are on the bipolar series, either broken bipolars or the periprosthetic bipolars, so kind of follow-up of the same. So it is more of a technique-based case. So this is a 70-year-old male patient, and he was unable to walk after a trivial fall on the ground in the house. And he had a past history of neck femur fracture, which was undiagnosed for around 1 month, treated by some quack or somebody. And he was operated 1 month back for a normal bipolar. He had a lot of medical condition. He had severe hypertension, he had kidney problems, and we made a right-sided diagnosis of proximal femoral fracture. So this is what we got, and it's kind of already, so the whole thing is kind of already in shatters. It has 2 to 3 fragments at the top and a horizontal fracture, and the bone plug is there distally. And it looked to me that the upper part, acetabulum, is kind of also fractured, but in CT scan it was not. So what were the challenges in surgery? So multiple medical comorbidities and unstable implant, cemented removal of cement, a bone plug distally, and severe osteoporosis. So this was his past history, in which he was treated for a neck femur, which was operated by a normal bipolar. During bipolar, which I had done myself, I had to be very slow and cautious because he was in bed for past 1 month and severely osteoporotic. And I could not, and everything went well for 1 month. He was walking normally. So what would be the treatment options? We had osteosynthesis with long trochanteric plate, revision with long stem, cemented or uncemented implants, and cortical allograft buttressing with locking plates. And it is difficult to get some allograft, which I would have preferred in such an osteoporotic patients. So pre-op planning, we had everything on the set, revision hip set, cement removal. I always keep a K-nail for my bailout, because in my experience in a few previous cases, sometimes they splinter so much, you have nothing to get out instead of wiring a K-nail and then coming back for a normal revision with a tube which is formed after the union. So this is a CT scan which was there, and it shows the fragments. So we went back inside. We had tied the rotators with ethibond. We found it stable. So we just had to untie the rotators, and we could separate out the piriformis and the external rotators. And after the releases, the hip was dislocated with the help of a bone hook to prevent any further damages. It was well cemented, and we used the fracture site as an osteotomy site for the cement removal. For the bone plug distally, as Dr. Rajiv had said earlier, we used a fenestration and then a corkscrew for the distal plug removal. So after this, we had multiple moving pieces. So like a trauma concept, we have to bring these moving pieces together to smaller pieces, single moving pieces, and then kind of couple them together. So first of all, we reamed the distal fragment and took a size, provisional size for the thing. Then what we did was we used the forceps for reduction of fracture, and we used cables instead of SS wires, and I found cables have a better hold than the SS wires. Then forming multiple fragment, we form a proximal sleeve. After forming the proximal sleeve, I use a K-nail to align the proximal sleeve with the distal sleeve. And the problem was when I used to reduce it or dislocate it, there was rotation instability. The distal femur would move out and the proximal would stay back. So I used it, provisionally fixed a long LCP with the SS wires so that I have a single fragment together and I could ream it properly. So after having this construct in place, in which there is a whole of single, it was like a normal, any kind of THR, in which you put a stem and then reduce it. So after reducing it, and I also did a prophylactic distal cabling so that the fracture does not propagate further. So everything was well. I put in a 170 mm implant and trial reduction was done. But when the trial reduction was taken out, even with the help of a bone hook, there was certain shearing sound and the fracture propagated distally as well as proximally. So we're back to the square one where we started. The distal cable which we had prophylactically done, the fracture side extended exactly till the cable was there. In the proximal part, it extended to the trochanteric area. So we again put more cables. If you can see, there is this is a plate we had hold on to earlier. If you can see, this is a fracture which was propagated. And we used more cables to pull it up. And then we put a solution stem. We reduced it, did a trial reduction so that we don't have it, that once you put a solution stem, we're not able to reduce it back fully. And then this was a final reduction. I used an intraoperative C-arm to check if I'm not perforating the distal cortex and to see if my things are in place. So this was a final implant. There was a talk of dual mobility for these kind of fractures. I prefer to use a bipolar cup because these are low demand elderly patient and I feel protrusion may be a problem, but with a large bipolar cup, it gives me a confidence of low dislocation rate. This is a post-op day 7. This is the long fracture fragment. This is a medial. You can see that the separate fragment which was there. And this is a post-op day at 2 months. So this is at 3 months. The osteotomy is holding well. The fractures are uniting. The person, he is able to walk. I don't know the video will play. So it is playing. He is able to walk with support at 3 months. I did not allow him full weight bearing, just for allowing the fracture to heal. So this is at post-op 9 months. He is well, functioning well. His implant is uniting. There is callus formation on the medial side, laterally. And this is the last video. And he has a slight lurch because of the limb length discrepancy, but otherwise he is walking normally and looks like he's, after a gap of 1 year, he is back to his normal self. And thank you for attention. We have questions from the house, sir.
Any question from the house? Amrita, I have a question. So when you put solution stem,
yes, sir.
How was the primary stability? Because I think you gave him bed rest or...
So the primary stability, if you see, I had done the reaming part right in the beginning, before even reducing the fracture. So the concept of solution stem is a distal fixation.
Yes.
So I had a sound distal fixation and knowledge what was the stem size going to be right before I assembled my fracture parts together. So I knew what my fixation is going to be solid, and I knew how long it has to go in. I could measure the stem diameter, stem length which was going inside to have a solid fixation. So that I can, when I reconstructed, I do not need to go up and down. That is why I had an exact idea of 170 mm stem when I had reduced it in the first instance.
So if given a choice, will you still use a solution stem monoblock, or you will have something else if given a choice?
I prefer to use these Wagner type floated distal stem because they have a better fit and they have a better rotational stability, and apart from that they have better proximal, the overshielding effect is less, but because of cost effect.
Yeah, that's right.
Secondly, there one more thing in the modularity part, allows me more freedom to play with it. I did not have to measure it pre-operatively and then go back again and then do it. So I can just put the stem in and forget about and then put the modular top up and then finish it up.
That's right. And there's quite often this recommendation that you add bone graft at the fracture site. See, they have very poor vascularity.
Yeah, I had the bone graft, the reaming part which I had taken out. In the distal part, I used it as small slurry and filled the fracture fragments together when I put it in. And I also wanted to use allograft, femoral allograft, to wire it together in these osteoporotic conditions, but availability is an issue.
How about putting a fibula on the inner side and then wiring it?
So fibula is a small round bone. I find that it doesn't take the curvature of the femur. When you put a femoral cortical allograft which has been split into two, it gives a solid fit, and it's like putting a...
Difficult to get allograft.
Difficult to get allograft, that is the reason.
So even in compromised situation, when you use fibula, that helps in
That helps you
osseointegration.
better. It is like getting the second best what we have.
Because they have very poor blood supply.
Yes, sir.
These bone fragments in whom we have put an implant and the previous one which had cement at place, they have poor blood supply. So it's always nice to add bone graft. So the healing is much better. So if you have a solid fixation distally and good osseointegration later on, you succeed. Anything you want to add, Vidi?
Yeah, I mean, a purely distally fixed cylindrical long stem made of cobalt chrome is a recipe for disaster. This is going to have a proximal cantilever effect, stress shielding, and this is going to break. So, it's good. It's almost predictable. I think the option, a better option would have been, I'm not criticizing what you have done here. I think you have done a wonderful job. But definitely a better outcome can be expected if you use a modular monoblock fluted stem like the Wagner.
Yes, sir.
I think that's the only thing I would say. And yes, I agree with the concept of bone grafting. If available, allografts are very convenient if you have strut fibular allografts which you can wire along with for the proximal fracture. And I fully agree with your decision of going back to a bipolar because of the extreme medical comorbidities which you mentioned right at the beginning. So I think a bipolar is okay in this patient.
Second problem, as we said, we always have that concept in government institutions of the money problem.
Agreed, 100% agreed, no doubt. We have worked there in government, we know. The implant you choose first, then you choose a technique because money is a big issue. But given ideal conditions, to give message to the house, that was discussed.
Sir, Dr. Ravi, sir.
As you rightly said, sir, this is Vancouver type 3B, so allograft bone stud is the middle side. I can see in one of your picture that the proximal femur going in the varus, slight varus is there.
Yeah.
Because of that, bone loss is there, I
Sir,
think.
I found that this thing of varus in the post-operative X-rays.
Slight varus is there.
Yeah,
Slight varus is there.
It's visible.
This one. If you see the, I think it's not coming up.
Can you put on, man? Can you show it?
So this thing looks a little varus. It has gone into the thing. The stem has gone towards.
Because of that bone loss at that side.
So I had reamed it centrally when I put it, but somehow the canal, when I put the stem in, it was going into this orientation. I need the help of faculty. What could have been better to avoid this varus? Because I tried putting it in center, but again it would take it that.
You tried this SS wire near this fragment. Tried to hold this fragment, but this fragment is not held.
This one was second fracture. This was a second fracture when it fractured. So the stem was already in place. So it was difficult for me to go around and do it, but this wire has slipped down from intraoperatively.
Thank you.
So if it is bored, it will take its own shape. That's why we're talking. That's the problem with solution stem.
So that
in a bored femur, if you try to do it, it will go hit one cortex and then deflect. It will go towards varus. Number one. Number two, we are not too sure because it's not very long follow-up. Is there an osteointegration? Is there a fibrous integration? We do not know. Because the last video you showed, patient still had antalgic gait.
Yes,
When 6 months or so. They're not too sure how it is going. Many of them, they can have just fibrous integration, the solution stems, not always osseous integration. And what Dr. BD was pointing it out, that's why we need to have proximal integration also using a bone graft. Some sort of integration will be there. They might have gone into fibrous and tilting into varus. We do not know.
See, one of the additional procedures which could have been done was to use a long hooked plate. You engage the hooks in the tip of the trochanter and by MIPO technique just pass it all the way down and get a distal hold. So if you have a lateral buttress, that will prevent this varus from happening. And and then augment that with bone grafting on the medial side.
Okay,
so that would have been perhaps another additional procedure which you could have considered.
And we all know they are all done in compromised financial situation, undoubtedly. They are all done in compromised financial situation. We are very well aware of this fact.
We already had a bipolar 1 month back.
So one lesson I have learned in my practice is that never, ever compromise your surgical principles on economics, because you do it out of good faith and this will be the first patient to sue you if there's a failure.
Yes, sir.
And that's why I never compromise. I tell them point blank. I say मुझे तो ये मालूम है मैं ये कर सकता हूँ. अगर आपको पसंद नहीं है या फिर नहीं बोला आप please कहीं और चले जाइए. I am absolutely point blank at that.
Then he will go to him. He can still manage with the low budget thing. Agreed. See, working in a medical college, things are different. Working in medical things are different. They might go to, anybody can go to court. Beggar can go to court that you gave him less money.
Thank you, sir.
If there are any further questions, or we should move ahead to the next session. So that DAS being handed over to the next session. Dr. Vinay Gupta.
For next
Dr.
session,
Prasad, please.
Dr. A.K. Gupta, sir, he chair the session. Dr. Arun Lal.
Please honor Dr. Gaurav
Dr.
Gupta.
Harish Pakkad.
Be here.
Sanjay Agarwal, sir, for this talk.
So whilst we set this up, the reason I'm here is that this particular session is on how to operate. And in fact, I'm going to talk about, hey, don't operate. I'm a surgeon. I'm going to talk about the medicine of orthopedics. So some of you were there yesterday. You saw how I deal with knees and hips. Today, I'm going to tell you how you can avoid surgery, particularly in a condition called AVN, which I'm sure all of you have seen since COVID. Who has not seen AVN post-COVID in this hall? Who has not seen AVN? Everyone has seen AVN. There is a methodology of treatment. There is an incidence of this disease, which I will share with you as soon as they can find my talk. Long COVID AVN. And of course, the emphasis is that you can treat post-COVID AVN successfully, medically. Mayank Vijayvargiya works with me. He's now a consultant. He's worked with me 10 years. He's helped me put this together. And in the JBJS of September 2022, we're talking about this year, they've accepted for publication of restoring post-COVID hips medical management for a surgical condition as the topic. And I think, getting it in JBJS America is really difficult unless we have something to present. And here we have, if this works, is Helen talking about give us your magic pills. Doctor Sahab, kaam karte raho and give us your magic pills. And that's what she looks like now. In COVID-19, we saw stay at home, stay safe, take steroids so that you lived a life. And that was all correct. There were 19.4 crores who were infected worldwide. That's what the WHO literature suggests. It could have well been more. So many lakhs died, and all of us have lost friends during this particular epidemic, pandemic. And those recovered patients from COVID, I mean, look at the long list of conditions that they have. I myself had COVID, very mild one luckily because it was this year. I had fatigue, I had shortness of breath, I had pain in my joints. I felt like I had very major flu, I had cough, and a whole lot of things that have happened. Musculoskeletal manifestations of long COVID have been described, but the one which we are concerned with, because all of us are seeing this now, is bone death post-COVID. At Times of India, Hindustan Times, all over, they referred to my paper which was published in The BMJ, now if you remember, even Chandli first published his first case reports on total hip in the BMJ, the British Medical Journal, because he knew that there would be skepticism from the orthopedic journal in those days, the British JBJS. But in July 2021, I published about 3 confirmed cases. And when you publish in the BMJ, it takes at least 3 months. When you publish something in something like the BMJ, you need to have done work for about 6 months. So these cases preceded the publication by about 9 months at least. And I had already started seeing these cases, possibly because of the steroids, possibly because COVID causes thrombosis of the vessels. The viral infection itself could be causing it. We don't know enough about COVID. Of course, it could be idiopathic. And here we have a patient, COVID at presentation, and you can see that in the MRI above. And after bisphosphonate therapy, within 3 months, the patient is getting better. Do you really think that if you had drilled this or decompressed it or put cells inside, that this would have been this good at 3 months? Case 2, at presentation, after bisphosphonate treatment at 3 months. And case 3, at presentation and at 3 months, things were getting better with my regimen. Now, the reason I emphasized this somewhat yesterday, and I'm going to emphasize today, you just can't give osteoporosis treatment of bisphosphonate and think it will work. I would strongly recommend that you follow my regimen, which I've been publishing for the last 20 years and using it for the last 25 years. The other thing that we found was that the mean dose of steroid in world literature suggests that after you've had 2 grams of steroid, are you really at risk? We were finding that 750 milligrams of steroid during these COVID cases, there was a risk. And generally, world literature says that 2 years after steroid exposure, you get AVN. And here suddenly we had, in 3 months, 2 months, they were getting AVN. So there was a lower dose of steroid and there was an earlier onset of the disease. And the aim of treatment, obviously, is to have improved quality of life, get pain relief, halt the disease progression, prevent collapse, and restore joint function. Whatever treatment you do, this is what you're aiming at for your patient. Is there a method? And the natural history of AVN, as we know from world literature, which you've read in Campbell or whatever book you've read, that at 3 years, 75% of the hips collapse, and you need a major surgical procedure in half the cases when they have been untreated. This is the degree of good results that you might get. I mean, less than 1/4 of these patients will do well. And within 3 years, you will need to operate them. Within 3 years, they'll need a THR, and this is what this whole course is about. How do you do a THR? When a patient gets a cerebral stroke or a myocardial infarction, it's immediate. It's an acute event, and your treatment principle is revascularization. And the quicker you do the revascularization, the better is the net result. Whereas in bone, it's diagnosed late. The question of revascularizing this with aspirin or Clexane or heparin is next to impossible. The bone's been dead for many months, not just 6 hours or 3 hours. So the treatment modalities that you may have learned of medical, not great. Core decompression, we are surgeons. I'm a surgeon. I am a leading surgeon in Bombay City, and I would like to be operating all these cases of AVN who come to me. And this is the degree of success that they have had with core decompression. It's inconsistent, it's variable with very limited success, and there's no real advantage to the natural history of AVN. We just said that untreated AVN, 25% of them survive. With treatment, they seem to be less than 25%. And these are all the various things that you may have heard of, hyperbaric oxygen, statin therapy. There's no benefit. You control the resorption to prevent structural failure is my treatment principle. So this is what happened when this particular building collapsed. in Delhi a few months ago, and this is exactly what happens in AVN. So you get critical ischemia, you get necrosis, you get an inflammatory response. That's when the osteoclasts come in and start eating away the bone. The bone becomes soft. Instead of being hard like wood, it becomes soft like a boiled potato. Bisphosphonates work for the anti-inflammatory and the anti-osteoclastic at these two ends. And then if they work, then you do not get the collapse. This is my treatment protocol. So all of you who have smart pens, you should have this on your phones at least. If you don't have the time to read my 15 papers on AVN and bisphosphonates. Zoledronic acid, and we'll talk about why. Alendronate in small doses taken more frequently so that you get 70 milligrams per week. Calcium and vitamin D3, because that you need daily. It doesn't work. If you can put up a brick wall without cement, it doesn't work. You need the calcium and you need the vitamin D. And like we said, small and more frequent doses are absorbed better, as is seen in world literature. And what is the rationale? Why the combination of two bisphosphonates? Alendronate is efficacious, so you can't just use any bisphosphonate. But even in alendronate, it has been shown in multiple papers that the effect, when you use it for osteoporosis, starts after 12 weeks and up to a year for the effect to happen. The second great thing about osteoporosis being treated with alendronate is only 2% gets absorbed. So if you have a patient who takes your alendronate tablet with tea, coffee, milk, it is not going to get absorbed. At the best of times, only 2% gets absorbed. Pain improvement, when you start using it for osteoporosis, this takes up to 3 months. You have a patient with acute pain, the drug is not going into his bloodstream because he's taking it orally. You think you've heard about the fact osteoporosis can be treated with bisphosphonates. 3 months of pain, he's not going to survive 3 months, so there will be decreased compliance. Intravenous bisphosphonates alone have not worked in AVN, and there are enough papers which show that. So, what does happen is that you get early blood levels when you give it IV and early pain and clinical scores improvement. So you need to give the first shot of bisphosphonates IV, and I've used zoledronic acid. It's freely available. When I started, it was 20,000 rupees. Now you get it for 1,500 rupees. Knowing that it works so well, we used it in transient osteoporosis and we published it as a single dose. It works in transient osteoporosis. That's what you see in 4 months. Otherwise, this disease is crippling for over 12 months. It's yet another case. At the end of 4 months, again, you can see how the disease has totally resolved. Transient osteoporosis. We've used it in SONC. Here you have a very painful condition. Half the time, we all don't know what to do. We might even offer them a total knee replacement because it's so painful. At 4 months, the disease is gone. Because zoledronic acid, the bisphosphonate, has got into the bloodstream. We're using the same principle. The bisphosphonate has to get into your bloodstream right in the beginning. And then you supplement it with oral. So there we are. Gives you early pain relief, early blood levels, obviously, because you've given it IV. Oral alendronate, which gets absorbed over a period of 3 months or so, 2 to 3 months, that prevents the collapse. You combine the two. So in this combined treatment, you continue for 3 years, because that is the natural history of AVN, is 3 years. You can't give it for 3 months or 6 months and hope it will work. And it's simple. It costs about 800 rupees per month. There is established safety of the bisphosphonate for 3 years. Anything beyond that, you start getting brittle bones. We've written about that as well. And it has been shown in animal experiments that resorption of necrotic bone is prevented by doses of bisphosphonate 4 to 50 times higher than for osteoporosis. So you need more of this drug to prevent the resorption of necrotic bone. Has been shown in animal experiments as early as 2002. So there is a rationale to my treatment of AVN. So repurposing of bisphosphonates, that is the term to use. It's not off-label anymore. It's repurposing. It is the practice of finding novel therapeutic indications for existing approved drugs. And you've seen this in aspirin. I grew up with aspirin instead of paracetamol when I had fever. Remdesivir, that was never described for COVID. Chloroquine, you and I have used chloroquine in malaria. 4 stat, 6 after 2 hours, 1 BD for 3 days for malaria. Do you give the same dose of chloroquine for rheumatoid arthritis? No. You have the same chemical, but there is a rationale for your treatment in different conditions. And therefore, in bisphosphonates, you use the combined therapy, which has been described by me. Analgesics are required, stick supports in the first 6 weeks, till you can start seeing a difference. I've written from 2001 onwards, we've been given awards. It's come in Arthroplasty, JBJS, Journal of Global Oncology, and a whole lot of medical journals which are all PubMed indexed. So if you go out of this lecture and you write Agarwala, that's the surname, Agarwala, and you write AVN, you'll have access to 80 to 90% of these papers. But you don't need to read them. Just if you've taken a click picture of my therapy, that should work for you. And these are the kind of conditions I have treated. And you may be aware of some patients who have been successfully treated. For those who are not successful, of course, now you'll have Dr. Prasad and the others telling you what to do. But this is the kind of cases at different stages of disease who have responded to my therapy. And it's not my, meaning it's mine. It's this combined therapy which everyone seems to forget. And our published work has shown that in stage 1, you get 98% success. That's a paper. Stage 2, there is a 92% success. In stage 3, there is a 77% success. We have not seen atypical fractures of osteonecrosis. So I think really there's a paradigm shift in osteonecrosis treatment. 20-year study published again in JBJS in 2021. So it's established, it's published, it's peer-reviewed. I think the chapter of management of AVN has been rewritten, is there in all these textbooks. We've used it in secondary osteonecrosis. Corticosteroids are life-saving, so don't stop it. But if you are getting patients who are getting this, well, you need to understand that get MRI and X-rays done on suspicion. In stage 1, you'll never see it without an MRI. Start my regimen of bisphosphonate therapy, which is this. So those of you who missed taking a picture of this can take it now. This is the treatment for osteoporosis, bisphosphonate management, what you see in avascular necrosis. Small and frequent doses are absorbed. Better I showed you how it's poorly absorbed, said so in literature. And in fact, this is what happens. If you do it carefully, this kind of a building can come up again. And let's see, can we hear her? So I've got a picture, I've got a movie with Alia Bhatt. There she is. So ladies and gentlemen, follow my regimen. That's the way to do it. Thank you.
Any question from house?
Any questions from the house?
Yeah, there is one question. Dr. Sanjay, is it working? Undoubtedly, it's an established regimen, no doubt about it. Any contraindication when you cannot give? Why I'm asking you, I got a patient, liver transplant with AVN. So any comorbid condition in which you cannot give bisphosphonates in AVN?
So you get patients who don't tolerate it because of their GI symptoms. We have yet another regimen which we have not yet published using another chemical. So, I've not published it yet. If your patient can't tolerate it, then you have to stop it.
Any other medical condition like?
Kidneys, they say kidneys, but I've spoken to all my nephrologists. They're okay with my dose. I'm not overdoing it.
Hepatic?
In hepatic, my physicians are not unhappy in any single case so far.
Okay, great.
So
Thank
far.
you.
कल को हो सकता है कि मालूम पड़े यार कुछ खराबी है, but so far. We're talking about, by the way, 20,000 cases that I've treated over 20 years. 20,000. I mean, you must have seen 20, 200, 2,000. I've treated 20,000 cases, and I'm talking about in published literature where I have a cohort that I can publish in an international journal. 500 case, 1000 case, which I can follow up. कितने cases तो मैंने treat किया होंगे, खराब हो गए होंगे, आप लोगों के पास आए होंगे, आपने operate किया होगा, I don't know about them. But the regimen I've done in 20,000 cases over these 20 years. So in the beginning it used to be 10, 20, then uska 100, 150 hua, and it's been exponential. Now after COVID, I've seen so many that I could write 2 papers in JBJS. Forget the BMJ paper. JBJS. I mean, to get a paper in JBJS, it gets scrutinized by too many people for us to be able to publish it.
This is regarding the core decompression procedure. While it is uncertain how much it influences the eventual prognosis of the disease, but one thing it does seem to do, it seems to dramatically decrease the pain. Now, in those cohort of cases where you were talking about severe intolerable pain for 3 months, so can you combine a core decompression in these particular patients?
So the answer is no.
In addition to your regimen?
The reason they get relief of pain is because you've taken away the edema from the bone. That's the only thing. They've not got pain relief because you have got new blood supply starting. We know that. Now, if you were to make dum aloo at home, what would you do with the aloo? You'd make holes in it, so it becomes softer. So the moment you do a core decompression, the bone becomes softer. The pain goes possibly because the edema has come off. If the edema has come off and the patient gets more relief, but the bone has become soft, it's going to compress, collapse, and need major hip replacement within 3 years, within 2 years, within 6 months. So you've not really done a patient a great deal of goodness. I think you've done a badness. When in 6 weeks, 3 to 6 weeks after zoledronic acid, the pain is going to disappear because it works to decrease the edema.
So for 6 weeks, do you keep them on opioids or something?
On?
Opioids?
Yeah, I give painkillers. I mean, you have to give painkillers. In fact, when they react to the zoledronic acid, you have to give steroid also. So that's all there in the papers. But you need to give them 3 to 6 weeks. By the end of 2 to 3 months, if they're doing well, they're going to come back and tell you they're doing well. They're better. So then you know that the disease is coming under control and you need to do this treatment for 3 years. Now, of course, there are certain cohorts which don't do well and they come to you for surgery after they've taken my treatment. From me, possibly. There are a whole cohort who come back and say, Doc, we are better. So all of you have smartphones over here. You go to YouTube and you write Yogesh Patkar. You may have seen him on ZTV. He's a dancer. He's a professional dancer. Yogesh Patkar. And write dance so you don't get his other things. And he took my treatment for 3 years. Fantastically better, but could not dance because he already was in a stage 3 when he started. I've done both his total hips. Because I have done his total hips, he sits and squats. You look at the video. Yogesh Patkar dance. He's the guy in the blue shirt.
Thank you.
That's it.
So what about using salmon calcitonin nasal spray during initial period?
You think it decreases pain? So if you look at the literature for salmon calcitonin, it works very well for spinal fractures. You can use it in addition if you wish.
Osteoporosis we do use.
I'm sorry?
For transient osteoporosis during pregnancy we do use.
Well, if it works, why not? But it's not going to cure.
No, it's
it's not going to cure. So if you're cutting down the pain, you can use opioids, you can use NSAIDs, you can use paracetamol, maybe you can use calcitonin, sure. That's it?
Sir.
So now you're going to learn how to do the surgery. This was how to avoid surgery. That's it.
Dr. Agrawala, please. One last question, if you can, please. The regime you said was 1,000 milligram of calcium. Whether it is elemental calcium or any different salt? Because every different salt has got different absorption.
you need 1.2 grams of calcium every day, right? 1.2 grams. It is assumed that if you take normal dahi, doodh, this, that, and the other, you get about 500-600. And if you are okay, you might be getting more. So you're treating a disease condition, you need to give enough calcium. But you need 1.2 grams a day. That's what world literature says.
Thank you, sir. Thank you.